Hi guys, in this video we'll be talking about a question you might see on USMLE. This is stress hyperglycemia versus diabetes. So let's get started. So let's say we have a young person who is 10 years old come to ED with 3 days of vomiting, diarrhea, and high fevers. So what are you thinking at this point? So EMS comes. You're an ED physician, and they're like, this guy was vomiting and had diarrhea for 3 days, and we checked his fever on the way here, and it was 104. What do? Well, you're thinking maybe gastroenteritis, right? He has vomiting, diarrhea, maybe he ate something, food poisoning maybe, right? But it's been 3 days, so food poisoning usually resolves in 24 hours or so, right? Even if it like max maybe 48 hours. Maybe he had exposure and again, he ate the same thing again and again, maybe, I don't know. High fever. Well, gastroenteritis can cause fever, but 104, that's really high. I'm not so sure about 104. This is a really high fever. Well, maybe pancreatitis. Why would he have pancreatitis? Maybe trauma. Well, maybe he has abdominal tenderness, maybe. Well, let's move on, see what other clues we have. He has asthma. He has allergies to shellfish. Could it be an allergic reaction? Did he eat shellfish outside? Well, would allergies cause vomiting, diarrhea, and really high fevers? Likely not, right? Is it an asthma exacerbation? Well, is he tachypnic? Is he short of breath? Well, right now, from vomiting and diarrhea, asthma, the respiratory system seems unlikely to be involved, right? So asthma, maybe unlikely, right? Well, father is diabetic. Could this be diabetes? Well, how does diabetes present? Polyuria, polydipsia, right? Like, unlikely, right? Because his major complaint is very acute, 3 days of vomiting and diarrhea with very high fevers. So we're suspecting infection. That's on the top of our list, right? Vitals show that he has temperature 104, he's hypotensive, tachycardic, and tachypnic, right? This is explained by the vomiting and diarrhea. He is dehydrated, right? Cardiac output equals heart rate times stroke volume. Stroke volume is N diastolic minus N systolic. When you're dehydrated, you have decreased preload, right? Decreased stroke volume, increased heart rate to maintain the cardiac output. That's Starling's law. And you know, when you're losing fluid out through both ends, that happens. And he's lethargic, right? Well, what is lethargic? I like, doing this one. So let's say this is the patient. He's on a bed in a hospital. This is you, and you're a physician. You're wearing the physician hat. Says, or doctor. I am doctor. Hi, my name is Dr. blah blah, and I will be taking care of you today. And the patient opens his eyes. He's like, okay. Closes it again. And then what? You're like, hi, I'm your doctor. Please wake up. I need to speak with you. He opens his eyes again. This time he's like, he looks at you, turns his head that way, and he looks straight at you, making eye contact. And then he closes his eyes again. That is called lethargic, when the patient is not completely awake, but is responsive to voice. Right? He's open his eyes and he will respond. He will tell you, my name is blah blah blah, and I am in the hospital, and I am this much years old, and blah blah, and then he will go to sleep again, right? So he's dehydrated, so you look into his mouth and you see that it's dry mucous membranes. And he has hyperactive bowel sounds, so he has like these tummy gurgles, right? So let's go on. So his labs show hyponatremia, hypokalemia, and hyperchloremia, decreased bicarb. Well, can an infection cause all of these things to happen? Well, we'll see. What else do we have to work on? Oh, there's glucose and ketones in the urine. What? Ketones in the urine? I have my diagnosis. It is DKA. But wait, hold up. What else do you have to support this? This A1C of 5.2. What is diabetes? It's 6.5 A1C. Greater than 6.5, and below that is pre-diabetic. So why are we thinking diabetes just based on the ketones in the body? That's not the only thing that can cause ketones, right? What about the hyponatremia, hypokalemia? Can diabetes explain that? Well, what happens during diabetes? You don't have insulin. Your blood, there's increased glucose. That's going to cause increased osmolality. That's going to cause your cells to push water out. And that's going to lead to your potassium being more concentrated inside the cell. And then it goes down its electrochemical gradient. It goes outside, right? So your total body potassium is decreased, but it will appear as though it's normal or increased, right? That's because when it goes to the kidneys, and this is my attempt at making a kidney, and your kidneys will have a nephron, right? And when you have increased osmolality, you have increased water out of the cells, all of that will go into your nephron and it will go down and come out in urine. All right, and that's why diabetics have polyuria, because they have increased filtration. This is called osmotic diuresis. When the fluid flows through at a high rate, you have less time to reabsorb everything. So you pee out your electrolytes. You're not able to concentrate the urine, so you pee everything out. So the potassium that came out the cell and the glucose is getting peed out. Okay? Is this osmotic diuresis? Well, it looks like it, you know. He has vomiting and diarrhea. That can also explain hyponatremia. It can explain hypokalemia because, you know, your stomach has potassium, has chloride, has protons, you know, HCl. All of that is getting kicked out. That explains this, right? His glucose is 290. What is going on here? This is a little confusing. Is this diabetes? Is this DKA? Is this HHS? Well, it can't be HHS, right? This is type 2 diabetes. This 10-year-old is not going to have type 2 diabetes with A1C of 5.2. Well, is this a new onset of DKA? Well, it appears like it, but the symptoms started 3 days ago, and none of the symptoms are weight loss is not there, polyuria is not there, polyphagia is not there. None of the diabetes symptoms are there. So why are we thinking DKA just based on labs? Well, what causes these labs in DKA? It's hyperglycemia, okay? It's hyperglycemia. It's not, well, it is the diabetes, but it's more specifically hyperglycemia in the diabetes that causes these labs. So what's going on here? This patient has hyperglycemia. This hyperglycemia state is caused by what? Well, it's infection. You guessed it, okay? He has a fever of 104. Do not ignore the fever because 104 is a really high fever. You need to have infection as number 1, okay? On your differential, and you need to treat it before ruling it out, because if you treat DKA and the patient has an infection, the guy's gonna go into septic shock, okay? You don't want that to happen. So this is a hyperglycemia state associated with sepsis. This patient had a GI illness, gastroenteritis, okay, which now has led to him being septic, and that explains his symptoms. Okay, that explains his vitals, okay, that explains his labs, okay, and we have effectively, this is more likely than DKA. What happened in DKA? Let's go back. Let's go over DKA or HHS. Our symptoms explained. Not really. Vomiting, diarrhea, there's no polyuria, polyphagia. Are the vitals explained? Support DK or HHS? Well, yeah. Vitals you can see all of those in these two states. Sure. Are labs explained? Well, you can see those labs. Sure, you can see ketones and glucose in urine. Hyponatremia, hypokalemia, decreased bicarb, increased sugars. Yeah. Sure. Is the finding of hemoglobin A1C not explained? Okay. So what's more likely? Hyperglycemic state, secondary to septic shock. It doesn't explain the fever either, okay? So this is very important. You can get tricked up when comparing hyperglycemic state to DKA, so be very careful. Read the question carefully and don't ignore the fever. And that will be all for this video. If you liked it, like and subscribe. And if you have questions, leave it in the comment section below.